I have nothing to disclose. Not a surprise to this audience, but alpha blockers are the cornerstone of medical treatment of male LUTs, recommended in all guidelines, but we have posted some debate on the efficacy of that. In our Dutch guideline for general practitioners, the advice is given to discontinue the use of an alpha blocker after 3 to 6 months of effective treatment. In the EAU guideline, such an advice is given as a suggestion to consider it in case of combination therapy with 5-alpha reductase inhibitors. In the Dutch guideline, there is no evidence to support this advice, and in the EAU guideline, only one RCT and one open label trial are listed. So we posed the question, what is the effect of discontinuation of alpha blockers on the symptom severity and urinary flow rates? For this, we performed a systematic review. We done this search early this year in PubMed, Embase, and Cochrane using the search terms listed. As you may expect, we did the search and data extraction in duplicate, and we used the Cochrane collaborations tool for risk of bias. We found 16 studies, of which 9 were on monotherapy alpha blocker comparing to placebo, and 7 were combination therapy. And if we focus on the randomized controlled trials, then we show in the risk of bias data that especially blinding was a high risk of bias. And combining the studies, we need to bear in mind that only 3 studies reported differences in IPSS scores at 3 months. Only 157 patients were included, and this showed a difference of 3.65 in IPSS points in favor of continuation. Comparable figures at 6 months, 1 more study, slightly more participants, and 3.25 points on IPSS scores in favor of continuation. As you may know, that 3 points is the difference that patients may consider as any difference they can mention themselves. We found in these studies no difference for Qmax at 3 or 6 months, and also for these comparisons only little studies with a small number of patients. So in conclusion, we found a small number of small studies and only short-term outcomes were reported. And these data do suggest that discontinuation of alpha blocker results in a slight symptom deterioration compared to continuation, and without any impact on urinary flow rates. And this seems to support both EAU and Dutch GB guidelines, although we must refrain from drawing straw conclusions.
Thank you. Now, this paper is open for discussion. I think in our daily practice, we have an idea that the baseline severity of the symptom is very important for the continuation of the medication. Have you found any information from the literature based on this point?
No, it must be so, but in these studies were too small and there were no subgroup analysis or other predictors for this effect after stopping. But you may consider if you have a high symptom score and the treatment is effective and you have a low symptom score during drug treatment, then it might well be possible that if you discontinue the treatment that you go back to the high score. I mean, it's average scores for the study population, so. And there's a wide variation. Yeah, Paul.
Abrams, Bristol. So can you just give the patient the choice?
Yeah, I think so. I think that it can be the choice. I mean, in my next presentation I will show you how often they stop themselves, but you can give them the choice. I mean, especially in primary care we deal with patients with low symptom scores but do want to try treatment, then they get treated, and after a while you need to discuss and say, well, there are 2 options. You can either stop and let's see what's happening, or either you can continue if you would like to. Yeah.
I mean, that's the good thing about alpha blockers is that they work straight away. So if they stop them, they can restart them but quite often patients forget to take the tablets for a few days.
Yeah.
And so they often know whether the alpha blocker is making a difference or not. Would you agree with that?
Yes, I would agree, although I think many patients are not, I don't know if patients often forget it for a few days in a row. If you forget it for one day, I don't know if you have the, more symptoms on the other day, but yeah, patients will be aware, yeah. But I think at least we can, as medical doctors, we are great to start medications. And we often forget that there is a chance to stop any medication. So that's the reason for multi-pharmacy and...
Please.
Yeah, Kari Tikkanen from Helsinki. Thank you very much. Very good. Exactly what you said. We teach people to prescribe, but not to describe. Yeah. And so this is important when we actually can describe the drugs. And so describe. So what about? So I was just wondering, like, what is basically important here? So you could argue that one of the things is that acute urinary retention or the surgery. We know that probably they don't affect, but just a quick question: how did you decide that you would take these two outcomes? Why do you think these are the most important outcomes? The IPSS score and flow rates, or is it just because you would expect information on that?
Well, I think at least IPSS score, the symptom score, is the most important for patients themselves. The other you mentioned, like acute urinary retention, it is very bothersome, but it's especially in primary care, it's a low frequent problem. And well, I don't know. I mean, as a GP, I'm not interested in urinary flow rates, to be honest. We don't measure them in primary care. So,
okay, thank you.
Okay,
thank you. Thank you.
So we move on next paper, 39. Prescription pattern of the alpha blockers for male lower inactive symptoms in Dutch men. The same presenter, Dr. Blanke.
Yeah, thank you. Again, no disclosures. As I just mentioned, the cornerstone of medical treatments for male LUTs is alpha blockers recommended in all guidelines, and I mentioned the discontinuation advice in the two guidelines. What we examined in the Netherlands is the prescription patterns for alpha blockers, comparing urologists and general practitioners. Dutch urologists' guidelines are well comparable to the EAU. I think the EAU guidelines are used. And we've especially focused on the two questions: did users have a period of discontinuation, as is given as an advice in the Dutch GB guideline, within the first year of treatment, and do prescription patterns differ between GPs and urologists? For this, we performed a retrospective inception cohort analysis with data from a large database with prescriptions from 60 community pharmacies in the northern part of the Netherlands, with over 1 million patients and over 100 million prescriptions. And those were not alpha blocker prescriptions, 1 million. And we selected men aged over 30 years of age. And we selected patients with a first alpha blocker prescription, which we defined as no prescription in the preceding 2 years, between 2006 and 2013. And we calculated the duration of usage based on all prescriptions for each patient, and at different time points we evaluated the current use and if they were current users with or without an interruption period. So in the full database, 23,000 men with at least one prescription of an alpha blocker, totaling 373,000 prescriptions, of which 12,000 prescriptions were first prescriptions in the study period, and well, exactly 44.5% were prescribed by an urologist, and a bit more than half were prescribed by a general practitioner. The mean duration of alpha blocker use was 584 days, but we need to be aware that the median use was only much shorter, so data are skewed. In this table, I show you the current use, starting with the 12,000 men who had a first prescription. After 2 weeks, 13% has stopped. And you see that after 1 year, only 37% of men were actually still on alpha blockers. And this didn't really differ between GP prescriptions or urologist prescriptions. Now for people who were current users at a different time point, we've listed the number of the percentage of people of current users who had a discontinuation period somewhere before. And then you see that from all people using it 1 year, approximately 30% had had at least one period of discontinuation. And also these patterns didn't differ between GPs and urologists, but there was a clear difference in age. Younger men more often had a period of discontinuation. Oh, this was one too much. So, to conclude, overall discontinuation rates were high, with only 37% of new alpha blocker users on active treatment after 1 year. Approximately 1/3 of patients still using it at 1 year after initiation have had a period of discontinuation during the entire treatment period. There were no differences between GPs and urologists. And we have one major limitation, that the indications for alpha blocker use and reasons for timely discontinuations are unknown from this database. As you all know, there are other indications for alpha blockers as well. And we don't know if the patients decided to stop or the GP advised to stop. Thank you.
Thank you very much. So now this paper is open for discussion. Any question? So I have one question. So did you take the switch from one alpha blocker to another alpha blocker?
Yeah, the information is in the database, but we didn't analyze it separately.
How many kinds of alpha blocker can you use in that hollow?
Well, there are 4 alpha blockers listed in the Netherlands, and I think tamsulosin and alfuzosin are most frequently used, I think in 90% of patients. But we didn't analyze it separately.
Okay. Yeah. Please.
Can you extend a bit more on the indication? I thought in the Netherlands that GPs had fairly standard practice and guidelines. So supposing that they are fairly well following those guidelines, you mentioned other indications. But the other thing is, if patients already stopped that early, you would think that the guideline is not strict enough. And do you have an opinion on that?
Yeah, sure. I think the main problem is that we do it like one size fits all. In all our patients, that's our guideline, male patients with LUTS, if they want treatment, we start an alpha blocker. And in many patients it's not effective because, it's the wrong group. But we don't, at least in general practice, we don't have any clear clues who we should treat and who we should not treat. So I think it might be the main reason to stop treatment after 6 weeks if you just mentioned there's no difference. So, and then other treatments should be chosen. Yeah.
Lior Katsuwu, urologist from Bedford, UK. It's not uncommon for me to write a letter to the GP. I'm discharging this patient back to you with an advice to continue on alpha blockers for the foreseeable future. From your 2 papers, does that mean I have to change my letter?
Well, I'm not sure. I think you need to discuss with patients what's expected and what they can expect. If you think they should, and there may be a difference between uncomplicated LUTS and men with complications. If they had a urinary retention, you might refrain from this discontinuation advice. But well, at least if patients don't come to you, to your office, and the GP needs to do the re-prescribing, yeah, you can give an advice, but at least the second study is not strong evidence to support stopping.
Does that mean a letter saying that I'm discharging the patient back to your care with an advice to carry on taking alpha blockers for a stipulated time and then withdraw it and assess your symptoms and then restart depending on how your symptoms do.
Well, I think there's room for that advice, and GPs also could consider that. And I think, I don't know the guidelines in the UK for GPs, but I think they work according to the NICE guideline, and the NICE guideline does not include a stopping advice. So I think we need to go through the NICE guideline committee first. Yeah.
Thank you.
Thank you. I have two remarks. First of all, you said that the age limit that you were looking for was above 30 years of age.
Mm-hmm.
So why did you choose the age at that young of age, 30, and not, for example, 50 or older? And the second thing is, have you considered the bias that could have appeared because of the prescription of alpha blockers for stone relief? Because a lot of patients, especially young patients, were prescribed in those years tamsulosin just to have a stone relief.
Yeah, I understand. Well, we don't know the indications. We've chosen, it's a kind of a pragmatic choice to go through the database that is very large to do the first selection. I don't know by heart the numbers, but the numbers of prescriptions in the younger groups were very, very small. And we did a subgroup analysis on age, and that shows a large difference. And may well be explained by the difference in indication for alpha blockers. Yeah.
So, for the last.
Abrahams, I think it's very interesting work, and it, of course, begs the question, are the right patients getting the right drug? Not only alpha blockers, but 5-ARIs. Probably more important than 5-ARIs because it takes longer for it to work. So my assumption is that GPs don't do flow rates. My assumption is that urologists do flow rates. So at least the urologists have a bit more information. But the discontinuation is just the same for both. So do you think we should worry about this, or should we just say it doesn't really matter because alpha blockers have a low incidence of troublesome side effects?
No, I think we should. It does matter. We are now doing a prospective study with new alpha blocker users, and the first, and we asked them after 6 weeks, do you still use it? And if not, why not? And people also from with a prescription from the urologist say, I didn't know that I should use it longer than 2 weeks. So information to patients is vital. How to use a drug when you don't come back to the office of the...
you wouldn't mandate pressure flow studies prior to medical treatment?
No, not yet. I mean, the alpha blockers are with only few side effects. So I think nowadays it's a trial and error with few complications. So.
Thank you.
Thank you.